Hello. The time is now 12:30 p.m. Eastern, the official start time for today's broadcast. The topic today is understanding and applying the SBIRT model, an efficient approach for primary and integrated care. This is part one of a two-part series. And now, without further ado, I'd like to turn things over to your host, Stacy Hull, Behavioral Health Task Lead for Alliant Quality. Stacy, the floor is yours.
Thank you. Good afternoon. I would like to thank you for participating in Alliant Quality's Learning in Action Network today and for your continued commitment to address the behavioral health needs of your patients. Before we get started, I'd like to share that in addition to the monthly webinars, Alliant is available to provide free personalized technical assistance to you and your staff. We can assist with trainings on the alcohol and depression screening codes, process flow to integrate the screens into your service model, and the collaborative care model, just to name a few. Please reach out to us. We will welcome the opportunity to work with you. I would like to turn your attention to the depression codes you see on the screen, as well as the alcohol codes on the next slide. These are Medicare reimbursable codes. We encourage you to screen your patients annually utilizing these codes. And now it is with great pleasure that I introduce Dr. Tiffany Cook. Dr. Cook is a board-certified adult psychiatrist. She is currently in private practice at Innovations Behavioral Health, LLC, where she provides both patient care and consultation services. She is also the psychiatrist for the DeKalb County Mental Health, Drug, and Veterans Treatment Court. Her past work includes faculty appointments at Morehouse and Emory Schools of Medicine as an assistant professor of clinical psychiatry. She also worked with Grady and Tanner Health Systems at Georgia State University's Counseling and Testing Center, as well as numerous Metro Atlanta community mental health centers. She has also worked in the field of trauma and HIV and AIDS in Haiti. Dr. Cook is a public speaker and a behavioral health advocate. And now I would like to turn things over to Dr. Cook.
Thanks so much, Stacy, for that introduction. I'm so excited to be with you to discuss SBIRT, and in the interest of time, I'm going to just jump right in. So by the end of today's session, you'll be able to name the three components of SBIRT, name 4 benefits to universal screening, name at least 3 behavioral health screening tools and the conditions they help identify, and to name the 4 steps associated with brief intervention. So what is SBIRT? It's an acronym that's been such a hot-button topic and getting a lot of buzz in healthcare as of late. This model was actually incited by an Institute of Medicine recommendation that called for community-based screening for health risk behaviors, including substance use. So the first component, the S, is an annual universal screening for unhealthy alcohol and illicit drug use. And then based on the results of that screen, a provider can identify what, if any, treatment is necessary for a patient and at what level. So that's the S. Next, the BI, or brief intervention. And it increases the patient's awareness of his or her drug use, and it's based on the principles of motivational interviewing. Then finally, there's the RT, referral to treatment. And this is where patients with severe use are referred to specialty treatment. This SBIRT model is best used in patients that haven't already been diagnosed with a formal substance use disorder, but it's better in those where you're trying to determine or figure out if there's an unhealthy use pattern. So why even use SBIRT? One is because it's evidence-based. A second key factor is that data has shown that early identification and prevention for risky substance use will ultimately lead to a decreased level of substance use. Another great perk about this model is that it can be used for any chronic condition, and it can be used in almost any healthcare setting, so in clinics, in the ER, in trauma centers, and inpatient. So now, referring back to those polling questions, what are the benefits of a universal screening? 1, reduces ER visits. 2, lowers healthcare costs. 3, early prevention. Or 4, all of the above. And it looks like the majority of people chose D, all of the above, and that is the correct answer. So, piggybacking off that question, do we need universal substance use screening? And the answer is a resounding yes. Risky substance use is a preventable cause of morbidity and mortality and a leading cause of disability. It can also exacerbate or even cause chronic conditions like diabetes or hypertension, cardiovascular disease, depression, anxiety, and many others. Risky substance use occurs frequently in primary care, yet it's underdiagnosed. And this is key because a lot of people would disclose their use, but they're just simply not asked about it. People are more likely to disclose their use to their primary care provider than to seek specialty care on their own. Or oftentimes people will seek treatment if the primary care provider suggests it, whereas on their own, they may not see their use as problematic. Universal screening also leads to less ER visits, less inpatient days, and lower healthcare costs, and that in turn decreases that morbidity, mortality, and disability mentioned in that top bullet. So time. One of the biggest questions I get about is time. In a busy practice, it may seem really cumbersome to have another task, but it only takes a few minutes to screen, and the screening process can easily be incorporated into a triage while the patient is in the waiting room. It only takes a few minutes, and for most patients, it will only need to be done annually. Remember, most patients are going to screen negative, and thus for the majority, screening will take about 2 to 5 minutes, and not all of this is physician time. In about 20% of patients, it may take 15 minutes, and again, not all of that is physician time. All new patients should be screened, and then follow-up patients should be screened at least annually. And once you get really familiar with doing SBIRT and with repeated practice, that time just tends to shorten. So how does this model work? So if you look over to the left, the first part, again, is screening. So if you screen a patient and the screen is negative, you want to reinforce their good behavior. So you want to commend them for not having risky substance use. If you screen and the patient gets a positive screen, then you want to ask questions to kind of determine the level of use. Some screens just ask one question, where a simple yes will give you a positive screen. So have you used any illegal drugs in the past year? If the answer is yes, that's only one question and the screen is positive. So in that case, you want to do a little digging and kind of establish severity level. So once you do that, if a person has high-risk use, you go into your brief intervention. And if they have severe use, that's when you go into your referral to treatment. So I want to talk about some of the screening tools that you can use. The first is the audit, and it's a screen for alcohol. It's kind of a go-to for alcohol screening, really a gold standard. It's really an excellent tool for alcohol screening. The assist and the NIDA modified assist are also tools that can be used, and they screen for stimulants, sedatives, tobacco, and misuse of prescription opioids. And that's good because we sometimes tend to forget tobacco use. The DAS-10 is another screen, and it's a screen for drug use excluding alcohol and tobacco. And the KJAID is a screen for alcohol and drugs. Some models suggest performing a brief screen and then giving a full screen only if that brief screen is positive. However, I find it more timely to just go ahead and give the full screen. It doesn't have that many more questions than the brief screen, and then if you give someone a brief screen, you have to stop and score it, and if it's positive, then go back and possibly give another screen and then rescore that versus just giving the entire screen, which just takes the patient a minute more, and having staff only have to stop once. It's a little bit easier for the workflow. In patients under 21, there are some specific screens that can be used, such as the CRAFT, and it screens for alcohol and drugs, the DAS-20, which is based on the DAS-10, and that's for adolescents, the Hooked on Nicotine Checklist. This can be used in teens and adults, and the S2BI, used in patients 12 to 17 for tobacco, alcohol, and drug use. So some non-substance use screens that I really want to point your attention to are the PHQ-9 for depression and GAD-7 for anxiety. Again, depression and anxiety, like unhealthy substance use, are leading causes of disability, of morbidity, and mortality, and again, underdiagnosed. But people often tend to want to receive treatment for their primary cares or when their primary care providers recommend it. So it's a good idea to complete these screens initially and at least annually as well, just like you would with your substance use screens. And this is so important because both depression and anxiety have a high comorbidity with unhealthy substance use. Of the two, I really emphasize the PHQ-9. Depression carries a little bit more stigma than anxiety. People are a little more likely to come in and disclose that they're feeling anxious. So you really want to make sure that you're screening for depression. Both are good screens, but please, if you have to choose between the two, make sure that you're at least doing the PHQ-9. And it's a very brief screen and will give you some good feedback to discuss with your patient. So we have another polling question. The SBIRT model can only be administered by the physician in the examination room. Is that true or is that false? So that is false. And again, most of you answered, 70% of you all answered that correctly. So let's talk about screening during a visit. In the next webinar, we're going to put the workflow for the whole SBIRT process together. But for now, let's focus on the screening flow. And these are listed in order from less to more time consuming for the provider. So one, screen in the lobby. You can use paper for this, a kiosk, a tablet, and that tends to be really effective as far as cutting down on staff time, but it tends to be more ideal in an outpatient setting. Next, you can do it during nurse triage, and that can be done with paper or your electronic medical record, or again, during the actual provider visit, and again, paper and electronic medical record can be used. Your medical record may have built-in screens, but it's relatively easy to build them into some different platforms if that's not already available. So let's talk about brief intervention. This is used when a patient's screen indicates moderate substance use. It's required in about 15 to 20% of those people that you're going to screen. And this is where you're going to educate the patient regarding moderate drinking limits and health risks if they're exceeded, to kind of encourage them to change their thinking and commit to a change and empower them to do so. This is where you problem solve. You want to build positive coping skills. And again, this is not to be punitive or to scare patients. This is a supportive measure to educate them and move them in the direction of setting a tangible goal to really decrease their use. So what are the 4 steps associated with it? The first thing you're going to do is raise the subject, understand the patient's views, and kind of build a rapport. So you ask permission to broach the subject of substance use, and then ask the patient what they think the pros and cons of their use are. Next, you want to provide feedback. You want to make sure you're reviewing the health risks associated with use. Then you want to enhance the patient's motivation to change. So you use readiness and confidence scales for this. So those are those rulers you see that may have a scale from 1 to 10. And on a scale of 1 to 10, how ready for change are you right now? On a scale of 1 to 10, how confident are you that you can change right now? Then finally, you want to provide advice, negotiate a goal, and thank the patient for letting you discuss this with them. And that's where you want to summarize everything that you've talked about. So in order for us to educate our patients regarding drinking limits, we need to know them. So in men ages 18 to 65, no more than 4 drinks per day and no more than 14 drinks per week is considered a low drinking limit. In women ages 18 to 65, no more than 3 drinks per day or 7 drinks per week. And in men and women 66 and older, no more than 3 drinks per day, 7 drinks per week. And one drink is considered a 12-ounce can of beer, a 5-ounce glass of wine, or a shot of hard liquor. So now you know the 4 steps of the brief intervention, but a common question is, what exactly do I say? So just remember the ORS mnemonic. You want to ask open-ended questions, give affirmations, reflect, and summarize. So an example of an open-ended question would be, what are the good things about using alcohol? Tell me some of the drawbacks with your drinking. You mentioned you have some concerns about your substance use. Tell me what they are. Or what would you like to do about that? An affirmation would be something like, I know it's difficult to discuss opiate use. Thanks for keeping on with this. Or I appreciate your openness about discussing your smoking. I can see that you're a very strong person. And reflective listening usually starts with a statement where you say something like, if I understand you correctly, and then you go ahead and recap in your own words. And summarize is just a recap. Other mnemonics to help you with what to say are frames and flow. And again, as you do this frequently, this will become second nature. So frames is feedback. You want to make sure you're giving the patient information about their substance use level based on the answers to their screen. Responsibility. You want to make sure that you empower the patient to have control over their behavior and consequences and let them know that the choice to change is theirs and that you're going to be there to support them no matter what they decide. A is for advise. You want to make sure that you're giving them some education on the harmful effects of substance use. M, menu of options. You want to give them some strategies to help them cut down. So not just leaving it at you need to cut down, but how can they do that? Like keep a diary of their use or identify high-risk situations, some alternate activities, give them some quitting guides, and you can even invite them back to an appointment with you to further discuss. E, you want to enhance motivation. So that's where you just really want to be empathetic. And S, self-efficacy, you want to encourage their confidence to change. And an even simpler mnemonic than this is flow, so feedback, listen, options. So again, this will become easier and second nature as you do it fairly often. So we've talked about screening. We've talked about brief intervention. Part 2 next month, we're going to talk about referral to treatment, and then we'll put this all together and go over a sample workflow of how you can incorporate all this into your practice in a timely fashion. These are my references. And if you have questions, we're going to open it up. But if you'd like to contact me further, here is my email address. Feel free to contact me with questions, want further information. I'm happy to do that.
And thank you, Dr. Cook, for a wonderful presentation. We do have an opportunity now for some questions. And Dr. Cook, it looks like we have our first question. Should the brief interventions be spread out over multiple visits, or can it be conducted in one?
Thank you for that question. It can be conducted in one, but you can also spread it out in multiple visits. Again, in the interest of time, and if the patient has a lot of questions, you can invite them to come back and discuss further. You may want to make a note in the plan part of the note that you're going to type to come back and revisit with them and check the progress that they've made on their goal. And once you check the progress, if you need to go through those 4 brief intervention steps again, you can. Or if something happens where you don't get to finish, you can spread it out. So if it can be done in one session, yes, but it can also be done in multiple sessions as well.
Thank you.
You're welcome.
And let's see, we have time for more questions. It looks like we've got one submitted. Can you provide an example of using the SBIRT model technique for other conditions?
So if you look at someone with diabetes type 2, you might want to do, your screen may be consisting of something you ask. How often do you monitor your A1C? How often do you do your finger sticks? How often are you complying with your diabetic diet? So it can be one of those questions or several. And if you see that they're on task with that, then if we can go back to that slide with the model, if we can pull that back up. If you see that they're on task with that, then you will go ahead and reaffirm and congratulate them on that goal. And if you see that, this is a slide. Okay, so if you see that, no, they're not monitoring their finger sticks periodically, no, they're not following their diet, then you want to say, okay, maybe you ask them to do finger sticks before each meal, and they do it once a day. So that may be high risk to you rather than severe use. So then you would do your brief intervention where you go through those 4 steps, ask open-ended questions. You go through the ORS model. You go through frames and flows. If you see that they're not complying with any of the diabetic recommendations, so not getting their eye exam, not getting the podiatry exam, not monitoring A1Cs, they've been hospitalized repeatedly for complications related to diabetes, then you're going to refer to specialty treatment. So you may say, now you need to go to this diabetes clinic or this diabetes education class. So that would be an example of how to do it for another chronic condition.
Thank you. And we've got another question. Is there any other training opportunities for individuals that will be working with individuals in SBIRT?
Yes. If you go to the ATTC website or SAMHSA, there are a lot of courses. There's a lot of materials. Massachusetts has a great SBIRT site. And also, if you want to scroll back and look at some of those references and click on there, that may give you a guide. But ATTCs and SAMHSA are great resources to get a little bit more information. And some of those offer continuing education credits as well for those.
Okay. And it looks like we've got another question. We've still got some more time. Can you role play doing SBIRT for a geriatric patient who drinks more than 2 glasses of wine per night for having a healthy heart?
Okay, who wants to be who wants to be the patient?
This is Stacy. I will be the patient.
Okay. Hi, Ms. Ho. How are you today?
I'm great. How are you?
Good. Thank you so much for completing the screen while you were in the waiting room. I appreciate that. That's something that we are doing every year just to make sure everybody's on track, and it's a screen that we give to everybody. I looked at the screen and noticed that you are drinking about 3 to 4 drinks a night. Is that correct?
Yes, because I understand that it's good for my heart.
Okay. Is it okay if we discuss that a little bit further?
Sure.
Okay. So I hear you saying that it's good for your heart. Are there any other reasons that you drink about 3 to 4 glasses?
Not really, but it also helps to relax me at times.
Okay. It helps to relax you. So I hear you saying you're interested in it for a healthy heart and helping relax. Do you think that there are any drawbacks to the amount of alcohol that you use?
I haven't seen any.
Okay. Well, you also have hypertension, and I know you're interested in a healthy heart. But drinking at the level where you are is a little bit above moderate, so it might actually be more harmful to you than helpful. Were you aware of that?
I was not aware of that.
Okay. Well, based on that, I think that it might be a good idea for you to cut back just a little bit. Is that something that you'd be interested in doing?
I would. What do you recommend?
Okay. That's something I will work with you on. I would say gradually cut back. If this week maybe instead of 3 drinks, you have 2, and then the following week you have 1. Is that something that you think would be helpful to you?
I think I can do that.
Okay. Or is there anything else that you think might work for you to kind of help you stay on track with that goal?
No, I'll just be mindful of it and I'll reduce it. I didn't realize it was going to cause additional problems for me.
Okay. Well, good. I'm happy to hear that. Is it okay if I check back with you next session to see how you're doing on that when I see you at your next appointment?
Yes, please do.
Okay. And just to summarize, it sounds like you right now are drinking maybe 3 glasses of wine a night for a healthy heart and to help you relax. Uh, sounds like you want to cut that back to about 1 drink, and that next visit would be a good time to check back with you. And at next visit, we can also talk about helping you relax, because you mentioned that as well as something you want to do. So some alternate ways to help you relax.
That sounds good.
Okay. Great. Thank you for letting me discuss it with you.
Thank you.
You're welcome.
That was a wonderful on-the-fly role play. Thank you both, Dr. Cook and Stacy. We have approximately 1 minute left in our session, so I'm going to turn it back over to Stacy to close us out.
Thank you. I would like to thank you all for joining us today. I hope you found the information shared to be of great value. Our next webinar will be held at 7 p.m. on August 24th. Dr. Janowski will present on integrating care for the whole person. And be sure to mark your calendars for September 21st at 12:30. Dr. Cook will present part 2 of utilizing and applying the SBIRT model. Remember, if we can be of assistance, please reach out. Enjoy the rest of your day.